Here we go. Hello, everyone. My name is Morotani. I'm from Nexus Motion. I am a physical therapist. When I'm not seeing patients or creating the next slides to educate other physios on the various topics on the human movement system, I get to hang out with some of the leaders in the world of physical therapy. So how lucky am I? Today, I am honored to have Dr. Paula Ludewig with me and have a short conversation with her about how she started out and how her journey has been as a physical therapist. So thank you so much for your time today, Paula.
Thank you for having me.
All right. Now, Paula is the division director of the physical therapy program at the University of Minnesota. If you have studied the shoulder at all, you must have come across many of her research papers on the shoulder kinematics. Before we get started on some of the questions, Paula, could you share with the audience, what are your roles at the University of Minnesota? Like, what does your day-to-day look like?
Sure. So a primary role currently is the division director. So that is the physical therapy education program, which is the largest component. But then also we have a geriatric residency. We have a very large substantive research enterprise. We have some faculty practice. A fair number of broad aspects trying to build towards the idea of physical therapy as a school in and of itself, which has multiple levels to it. But right now we're just on our way towards that. So, and then I also teach and do research myself and a little bit of clinical time. So.
Oh, very good. So you are actually still getting to see some patients in the clinic.
A little bit. It's about a couple hours every other week. So very limited, but it's a nice way to link things back to the research and the teaching.
Yes. Now, going back to the origin story, Paula, how did you decide that you wanted to become a physical therapist?
So at the time when I went to school for physical therapy, it was still a bachelor's degree in the US. And I actually in high school then was trying to decide where to go to college and what to do in college. And I didn't really know anything about physical therapy, but my mom was a nurse and I really liked health related fields. I didn't want to become a physician. The idea of emergency room medicine, that's too quick of a decision and too life-threatening of a mistake, right? And so I became interested in exploring physical therapy and continued to do that for then the next year or so into the first year of college. I went to a school that had a physical therapy program and after some exploration decided that that was definitely what I wanted to do and have never regretted that decision. So.
Now, I noticed that you got your higher education, the degrees from University of Iowa. Are you originally from Iowa?
No, I'm originally from Minnesota. So
okay.
I went to do my undergrad, my physical therapy degree in Duluth, Minnesota, which is northern Minnesota. And then when I got my first physical therapy jobs, one was in South Dakota first, which is to the west. And then I went to Iowa for my second clinical job, and that's south of Minnesota. And from there is when I decided to go back to school. And so that's how I ended up at the University of Iowa for my master's and my PhD. So.
Gotcha. Yeah, I did get to spend about 4 years in undergrad in a small college in Iowa. So a lot of people get surprised to know that Iowa is not exactly flat. It's just this nice rolling hills, very pretty. Yeah.
What area of Iowa then?
That was called Grinnell College. It's right off of the I-80. Yes.
Yep, I know Grinnell. So that's great.
Well, you probably mentored many PhD students and PT students as a professor, but along your way of becoming a leading PT, who influenced you the most in your PT career? Like, who are your mentors?
Yeah, that's a hard one because there's so many people that have an influence, right? And you don't want to leave anybody out, but I'll sort of broadly categorize certainly my PhD mentor, Tom Cook at the University of Iowa. He was willing to take me on as a master's and PhD student. And he did more ergonomic type work. And so that's where I started, related to some of the things related to the shoulder, but obviously grew and developed from there. But he gave me the opportunity to really initiate and start to get excited about research, because I didn't really have much knowledge of that previous. Shirley Sarman for sure, and more so as I got to know her more and got further along in our research, and particularly of late in understanding the importance of diagnoses for physical therapists to be providing those. I apologize, my cat is making noise in the background there. But as far as individuals, definitely would need to mention both of them. But overall, I would say PhD students that I've worked with really influenced me a lot, because they just challenge you. They make you articulate what you're thinking, and are skeptical of things and look for the answers, but at the same time are the people who help make all these things happen, because all the research takes a lot of time and a lot of effort, and it's really been able to expand what I could do over the years by working with PhD students. And then lastly, I'd say patients themselves. They're just so much fun to work with, and so much reward in being able to help and coach them along. And we don't always succeed, but they're always so grateful, and they're the ones who have to actually do the things that allow us to be successful, right? And I'm certainly not a person who believes in physical therapy as a passive intervention. And so I would say lots and lots of people have really influenced me along the way, and many others. So.
Yeah, that's great. I love how your answers also included those who you have mentored. I mean, I think it was so inclusive, and oftentimes we think of mentors as somebody who, is maybe sort of like older than us, but that those kinds of answers really inspire me. So thank you for that. There was a little mention about how your PhD advisor kind of influenced you into getting more interested in the shoulder, but how did you choose to go into research? Were you sort of like, were there missing answers in the clinical setting, or how did that get started?
Yeah, so back in getting my bachelor's degree, I did do a research project for my bachelor's degree. It was just a very basic survey of, I think, around continuing education interest or something like that of practicing therapists. But I liked the process, and that was always in the back of my mind. But when I first went back to school, I actually thought it would be towards becoming an educator predominantly, and I really wanted to teach. And I still liked the clinic, so I thought maybe I'd get my master's and do a little more clinic work and start to teach. But as soon as I got to Iowa was one of the predominant research institutions at the time in physical therapy. And I just really loved the process. The idea of asking questions that don't have a known answer was both scary and really exciting to me. And you really quickly, it's sort of by accident, become this expert because you're thinking about these things that other people aren't thinking about as much. And so I just really enjoyed the process. And the University of Minnesota has a slogan. It's called "Driven to Discover." And that to me just really fits my personality really well. The questions are a lot of times more fun than the answers, right? Trying to figure out how things work. And certainly that made the shoulder really interesting because there was so little known at the time that I started doing my research in that area. With regard to why the shoulder specifically, I actually started off when I went back to school, I was interested in the foot. So there were people at Iowa, faculty at Iowa, and PhD students who were doing orthotics research and things like that. And so that's part of the reason I was interested in it. And I really I did orthotics in practice, and I had gone to when the foot hits the ground course, and I really loved that course, which is very biomechanically based. But then my advisor actually was supposed to be Gary Soderberg. I don't know if you're familiar with Gary Soderberg. He was
Yes,
at
I know
Iowa
of
at the
him.
time, and he left after I was there about 6 months to start the new program, the first DPT program at Creighton. And so I needed a new advisor, and Tom Cook was willing to take me on. But he's like, what about, there's a couple ideas that some people have talked to me about the shoulder. I've done a lot of foot research in the past, and I'd really rather not do that. So it was really sort of an accident that I ended up starting in the shoulder. And then at the time, there was hardly anyone doing it in that area. Everybody was studying the ACL. But the amount of research wasn't there, and it was just really fascinating to me. And again, very complex biomechanics, similar to the foot in that regard. And so the rest was history, as they say, that I just continued on in that area, and I've really enjoyed it. And we still certainly haven't answered all the questions about how things work in the shoulder. So.
Yeah, that's so great. It's like the foot and the shoulder, like almost
Right.
opposite ends
Exactly.
of the body.
Opposite parts of the body, but.
That's great. Now, as a scientist, it must be, just as you said, it must be so exciting to discover data or information that no one knows yet. But I'm sure not every day is like a discovery day.
Right.
So what are the challenges of being a researcher?
Yeah, I think there's certainly long periods of time, particularly if you're working in complex areas, there's a long periods of time of processing data. I think data collection is fun because it gets you back to that interaction with people. And when you're starting to see the results, that's really fun to start to figure out what that means. And there's this biggest chunk of time is really in between those time points when you're processing data and you're figuring out that your code doesn't work exactly the way you thought it did, or some of your results don't make sense and you have to redo them. And there have been times when the students in the lab will joke, and they say it's called research because you have to redo it so many times in terms of some of the data processing. But I think that's one of the hard things. So there can be these long sort of mundane periods, particularly when you're a graduate student and you're doing all that processing yourself. Other than that, I guess I really like the whole process. It's varied, but at the beginning, you're trying to figure out what we already know. I love reading the literature. In fact, with all the administrative roles that I have right now, I really miss the opportunity to just really dive in and figure out there's so many things that people have sort of hinted at in their papers a lot of times that haven't been further explored. And you can pull out some of those sort of pearls of wisdom from people years ago. And then I love developing the study. I actually like writing grants. And in terms of proposals, I like getting them better, but I do enjoy writing them. And then ultimately, again, collecting the data, even aspects of processing the data, I think are fun. And then the most fun to me is, again, interpreting the results and building out the discussion and what does it mean. The other challenge, certainly in research, is getting funding, because it does take so much effort, and you have to pay people to be able to make a living in doing this process. In the way research works in the US, for the most part, you're having to help pay for the facilities that you're working in and parts of your own salary to be able to spend the time on the research and all of those things. And so that's a constant thing that's sort of hanging over. Even though I like writing grants, it's a challenge to make sure you've got everybody covered, for the next semester or the next year in terms of your students or your other researchers who are working with you and things like that. So I would say the data processing and the ensuring of funding are probably the two biggest challenges that I experience anyway.
Now, I'm sure it varies from the amount of funding you received in a given year, but on average, how many grants are you writing in a year?
Yeah, so it's much less for me now, but because again, I have a pretty large administrative role, but I'm trying to shift back again. We just got through our accreditation towards the end of last year, and so that relieves some of the administrative burden. But even on a sort of slow year, there's usually 3 or 4 grants that you're putting in, and they vary. They're not all big NIH grants. And some of them are contributions to other people's proposal, so you're not writing a huge amount of the project. But you know, if you're writing really large grants, there's an NIH cycle 3 times a year, and if people aren't funded, they're usually trying to get in a large grant at each of those points in the cycle if their predominant role is more doing research. So
yes, wow. And I know you're a very dedicated researcher, because is it true that you have placed bone pins in your own shoulder to get some data? I thought that would be one of the hardest things about your research.
Yeah.
How did that come about?
Yeah, so when I did my PhD thesis, I used surface sensors, which were very common at the time, to track bone motion, but we never know exactly what's happening at the bones underneath. And so it actually started with wanting to do validation of the surface sensors that I was using. And as I learned more and more, it became apparent that even though we were going to be able to get some answers from the surface motion, we just weren't going to know the accurate information without getting to the bones directly. For example, you just have to ignore the translations of the joint with surface sensors because it's just so inaccurate. And the translations are a lot for the glenohumeral joint, for instance. And so it started off as just trying to validate on 1 or 2 people that we were tracking things okay with the surface markers. I actually tried to do that at Iowa yet, but they didn't let me because I was a student and it was an invasive study. I wouldn't have put the pins in, of course. We had a surgeon who was involved, but they pretty much tabled the discussion with the institutional review board and said, nope, this isn't a good idea. So I just waited. And then when I came to Minnesota, it was one of the first studies that I submitted to our institutional review board here, and they scrutinized it quite a bit, but then they approved it. It turned out at the same time, or near the same time, they were doing a study where people were putting pins into the spinous processes. So to do spinal motion testing. So it's not unheard of. It's a guarantee that there's going to be some pain. But otherwise, it's actually safer than most drug studies that get undertaken, to be quite honest. It just, again, seems more invasive to us as opposed to taking a pill. So in terms of doing that, though, I felt I needed to really totally understand what I was asking people to do. And so I couldn't be the first subject because I had to be there to figure out the processes, but I was the second subject, and one of my PhD students ran that experiment then with me as the subject. And to be honest, it wasn't that bad for pain because we were using lidocaine into the periosteum of the bones, and relatively smaller bones for your scapula and the clavicle. It was pretty minor. There's definitely some aching in the humerus from it at the time, but really, really valuable data, and really unique data set, because we ended up testing 24 people total, about half of whom were asymptomatic and half of whom were symptomatic. And we still are actually still doing some papers with some of that data because we had them do quite a few different things once we had the pins in place, because it was just such valuable information. So
Yeah, well, that's true dedication. So thank you for doing that. But you're not just a cutting edge researcher, you're also an educator. How do you envision physical therapy education in the United States in the next, say, 10 to 20 years?
Yeah, so that's a long time to project, but I love projections. So my best projection, well, I think there's a couple things. One not so good maybe, and one that I think will be really fascinating to watch. But the one that I don't think is so good is I think we're going to start to see a split of education programs towards those who are really trying to get students out pretty much with the shortest possible path. There's a lot of accelerated programs that are coming out now and are really sort of saying, well, you know, there's shortages of physical therapists and they're only going to make so much money. So we're trying to reduce the cost of education, but you can only learn so much in a certain period of time. And so I think that'll probably produce reasonable entry-level providers. But I really like to see us go and get stronger, particularly as diagnosticians, consistent with what Shirley has been talking about for years and years, and primary care providers and all those kinds of things and opportunities. And I just don't see that happening from that pathway. And so I wonder if we won't develop sort of two pathways where some schools are trying to produce that higher level primary care provider with stronger skills coming out initially, and others are trying to sort of meet that sort of immediate need in terms of producing providers. So that's one thought. I don't know if that'll happen, but I wonder. The other that I think is really fascinating, but is going to be scary to people, is artificial intelligence. People want to say that we as humans are going to make the decisions and figure everything out. And I don't ever think we're going to be replaced. But I think we need to embrace using technology to help us in our decision making. You know, even simply looking for patterns, which is again a big part of what diagnosis is. A computer can start to pull out those patterns a lot more quickly than we can. And we're just not fully consistent in our pathways that we take and things like that when we get sidetracked by an interesting finding in our clinical exam or things like that. And so I hope that we as a profession will embrace that rather than sort of being afraid of it, and learn how to help drive algorithms towards the most success. We're going to have good data to put into it in the first place. And that's a challenge right now because a lot of what you would pull out of a chart or something like that is not really super strong data right now. But it's pretty surprising when you think about it that it's 2022 and we're using plastic goniometers and you know, manual muscle testing sometimes without even using a handheld dynamometer. And some of these things, there are tools that are getting better and better that can help us measure motion and measure the associated impairments. And again, sort out from a subjective examination, what are the critically important symptoms that go with certain movement patterns and things like that. But if we embrace it, I think it'll help us move this idea of diagnosis so much further forward more quickly. And so I hope to see some of those things into the future. So.
Wow, I didn't even think about AI, but that is such a good point. Thanks for bringing that up. Thanks, Paula.
Sure.
And this coming October, you have agreed to return as a guest speaker for the Movement System Monthly, which is the program for the Japanese movement professionals. Could you say a quick few words for the Japanese community? In English is fine, because we're all looking forward to learning about the latest findings in your lab.
Right. So I always enjoy it. So it's fun. And I know I had the privilege of going to Japan actually several years ago and meeting with some of the Japanese therapists. And I was very impressed with the biomechanical knowledge base that Japanese therapists bring into their practice. And so we'll be talking more about some of the studies that we've been doing around movement classification and using the tool that we use now instead of sticking pins into people is video radiography, where we can take and actually capture the underlying bone motion and put it back together with three-dimensional imaging models of all the bone structures and things, and animate the underlying movements in pretty precise ways. So we'll talk more about those things.
Well, great. Thank you so much for your time today, Paula. I hope you have a good rest of the summer. Everyone, keep your eyes open for the new findings coming out from Paula's lab. I think understanding the mechanisms will help us figure out why our patients are having shoulder pain in the first place or still not getting better. And it'll only make us better professional of the movement system. So thanks, everybody. See you next time.
All right. Bye-bye.